Hello everyone, I'm going to tell you all quick ways to solve USMLE questions on malabsorption. I will first tell you when to suspect malabsorption and what is unique in each type which differentiates one from another. Let's begin. A typical presentation of malabsorption will be when a patient comes in with diarrhea, weight loss. These patients might also have vitamin deficiencies of A, D, E, and K. The clinical vignette might also mention a positive Sudan stain on the feces of these patients. This is because this stain identifies lipids. The main pathology behind these syndromes is either an issue with the small intestine villi or the absence of an enzyme. The first one on our list is celiac disease. These patients are intolerant to gluten. In these patients, gluten causes diarrhea by destroying the villi. Gluten contains gliadin. Gliadin is deaminated by tissue transglutaminase. In these patients, antibodies, majorly IgA, is present against deaminated gliadin peptide and endomysium. So, the deaminated form is presented to T helper cells which cause tissue damage and destroy the villi. These are the villi and these are the crypts. Since villi are destroyed in these patients, there is villus atrophy and the crypts become deep and undergo hyperplasia. There are a lot of lymphocytes in these cells. The part that is majorly involved in celiac disease is the duodenum. Celiac disease is an autoimmune disease. It is associated with HLA-DQ2 and HLA-DQ8. What makes this unique is the skin findings. Dermatitis herpetiformis is seen in these patients as IgA destroys the connection between the dermis and epidermis. This gives an appearance similar to herpes. That's how it gets its name herpetiformis. These patients are at a risk of developing T-cell lymphomas. A fraction of these patients may also have IgA deficiency. Let's move on to lactose intolerance. Diarrhea in these patients occur after consumption of dairy products. The main issue with lactose intolerance is the absence of the enzyme lactase. Lactase breaks lactose down. In the absence of lactase, lactose remains in the gut. Lactose is osmotically active, so it attracts a lot of water into the lumen and causes osmotic diarrhea. Since there is no structural defect, the villi look normal. However, in lactose intolerance secondary to viral diseases, there might be villus destruction. pH of the stool will be low because lactose gets fermented by the bacteria in the colon. Fermentation also leads to the production of hydrogen. This is why the expired breath of these patients will contain a large amount of hydrogen. This is known as lactose hydrogen breath test and is used for diagnosing lactose intolerance. Tropical sprue. In this disease, there is damage to the villi due to a microorganism. So, this disease is responsive to antibiotics. Topical sprue mainly affects the duodenum and the jejunum. Since folate is absorbed in the jejunum, these patients can develop megaloblastic anemia. Tropical sprue, as the name indicates, is more common in the tropical regions. The pathology behind Whipple disease is the presence of T. whippleyi in the macrophages of the small intestine. Since there are many macrophages in the lamina propria, the lacteals here get compressed. Lacteals are essential for absorbing fat. Compression of the lacteals leads to fat malabsorption. Macrophages aren't able to destroy the bacteria completely, so it remains inside them. This results in a positive PAS stain. Whipple disease can also cause arthralgias, cardiac, and neurological disease. Crohn's disease is unique because there will be multiple lesions throughout the GI tract known as skip lesions. Fistulas and kidney stones are also associated with it. Eye findings such as episcleritis and uveitis also point towards Crohn's disease in a patient with malabsorption. Non-caseating granulomas can be seen under a microscope, and these are typical for Crohn's disease. Pancreatic insufficiency is also an important cause of malabsorption. Lipase is a pancreatic enzyme. It is required to break fat down to make it easy for the intestine to absorb. This is the reason why pancreatic insufficiency leads to lipid malabsorption. Pancreatic secretions are alkaline in nature. In the absence of enough enzymes, the duodenal pH in these patients will be low. Decrease in fecal elastase levels suggests pancreatic insufficiency. D-xylose absorption will not be affected. Pancreatic insufficiency is majorly seen in chronic alcoholics. Patients with cystic fibrosis can also have pancreatic insufficiency. Clues like recurrent sinopulmonary infections and infertility in men will help you spot this on a vignette. Zollinger-Ellison syndrome is caused by a gastrin-secreting tumor. Patients will have a history of multiple ulcers. Epigastric pain may be a common symptom. Gastrin levels in these patients remain elevated despite the administration of secretin. The high acid content in the duodenum results in an activation of the pancreatic enzymes and leads to fat malabsorption. The tumor can also destroy the parenchymal cells of the pancreas, leading to pancreatic insufficiency. I hope this video was helpful. I made a similar video on dementia a few weeks back. Do check it out and find out easy ways to identify different types of dementia. Also, there is one malabsorption disease which I didn't mention in this video. Do let me know what you think the disease is. After watching this video, do check out FreeMed site's notes on malabsorption diseases. They're really concise and will help you with revision. Thank you.